All right, everybody, we might get started. Let me just begin by paying my respects for the elders, families and descendants of the Wurundjeri people on whose land this event is taking place. So, as you'll know, if you've been to the last three lectures, this is our final May lecture, the May lecture series being one of our public relations exercises where we try to introduce the wonderful research and thinking that we do here in the School of Psychological Sciences. And those of you who were here 3 weeks ago will have heard eminent alumna Susan David give her presentation, and we've also had presentations from Scott Griffiths last week and from Simon Cropper on very different sorts of topics. If you missed those lectures, unfortunately, you've missed them forever, except for Simon Cropper's, which is on our YouTube channel. So if you'd like to check that one out, complete with sound effects, that's something that you can check on, and you'll be able to relive the pleasure of this lecture on YouTube within a few hours if you so desire. So I'm delighted to be able to introduce our fourth May lecturer, which is Professor Kim Felmingham. Kim recently joined the school as the new chair of clinical psychology, the position that had been vacated by Professor Henry Jackson when he retired a couple of years ago. We were delighted to acquire Kim from the University of Tasmania because she's a true expert both as a researcher and as a scholar, but also a very seasoned clinician, and she brings an integration of those three perspectives to her work on trauma. She's best known as an expert in the psychology of trauma, and has a rather distinctive take on that, but has also written and thought extensively and deeply about depression, anxiety, anger, traumatic brain injury, and a variety of other topics as well. What's, I think, especially important about the work that Kim does is that it is biological in orientation, while at the same time maintaining a sophisticated psychological view as well. So Kim explores endocrine function in the context of post-traumatic reaction, neural aspects of it, genetic predispositions to post-traumatic reactions, and also integrates that with a focus on treatment. So it's not just about what is going on, what the mechanisms of post-traumatic reactions are, it's also how best do we remedy them, and unusually in her field, combining those two foci. How do the brain mechanisms of post-traumatic reactions respond to different kinds of treatments? So without further ado, actually one last thought. This university used to have inaugural professorial lectures. We've sort of done away with that, but this sort of functions as that. This is the first public lecture that Kim has given of many, I'm sure, and so let's make an especially warm welcome to Professor Kim Felmingham.
Thanks, Nick. Is it all on? I'm hoping it's all on. Good, that's much better for me. And thank you for the words very senior there. I appreciate that, so that's great. I feel very senior because I just managed to bathe children, wash, cook, feed them and get here within an hour and a half, so that's pretty good. Anyway, so my topic, as you can see, is modest. It's, you know, can we predict PTSD, enhance treatment and prevent it? So, you know, by the end of today, you'll know everything and we'll all go home and problem solved. But no, really what I want to do at the moment, I'm going to cover some of my work, but not just some of my work, because, you know, there's a lot of very smart people working in this field. So I'm really wanting to give a sort of snapshot about what we think is happening in the world of PTSD. And as Nick says, it is predominantly a more biological perspective than a sociological perspective, and there's certainly a lot of other models, including cognitive ones, but my take is more biological here. So I'll be presenting, you know, some of the basic ideas that we've got, some of the findings, where we're currently at, and then probably some more that are new directions, where we really haven't got a great evidence base yet, but it will give you a bit of a flavour or a taste of where the field might be heading as well. All right, so I haven't timed this. I'm jet lagged. I'm hypomanic naturally, so we can see what will happen. We'll see. I might finish in 20 minutes or I might talk forever. We never know. So the, you know, recent events, Manchester, just shockingly over the last 24 hours, We do know that PTSD's been around for a long time. It wasn't recognised till 1980, and that was only in the context of Vietnam veterans. It's been around, though, since the 80s, and we've become increasingly aware of the different types of traumas that may actually result in this syndrome or this condition. And what's concerning over the last 10 or 15 years is the frequency of sort of mass trauma events. So we're looking at an increased frequency of natural disasters, an increased frequency of terrorist events. So, you know, I thought I'd address this in the initial few slides before I get into some of the science and the research that we're doing, because it is something that's just so topical. A lot of the studies that have been happening with this really kicked off around Hurricane Katrina as well as September 11th to start to assess, you know, how many people are actually going to be traumatised. And one of the really important questions driving that was, what about the media exposure? Because we know with our 24/7 media cycles now how saturated we get with the trauma imagery. So the thing I think that's really encouraging, even from these studies that are coming out, is it's still a message of resilience. Okay, so about 30 to 50% of people, when they did studies after the London bombings and after 9/11, actually did express significant shock, distress and anger, but that's perfectly natural and normal. What we do know, though, is that most of those acute stress types of symptoms tend to go away by themselves. So there's a natural recovery process that occurs. So, you know, with this, September 11th, the government there actually put up a huge amount of funding for counsellors and counselling services. So every counsellor and his dog raced to New York and set up signs, and it was barely used. So the question of how do we respond in the immediate aftermath of trauma is a really important one. But the fundamental message in those first few hours and those first few days is not with psychologists. You know, do we really need psychologists going around with clipboards and questionnaires? Do we really need to actually force people to talk about the trauma or engage in psychological therapy at those times? The answer is no, we don't. You know, what people really do need is a cup of tea, somewhere safe, maybe some clothing if they don't have it. If you're parents, you really need information on where your children are, and you need information. You may need reassurance, some basic information about trauma reactions and how common they are and what you might expect over the next few days, what's sensible to do and not do over the next few days. But in terms of actual therapy, we don't need it at that time. So I wanted to raise critical incident stress debriefing because that is a model of intervention in the immediate aftermath of trauma that was around. You know, that arose from very well-meaning instincts and motivations. However, people didn't do enough of the empirical research to see if it was actually effective, which is a little concerning. And now that they've done some research around critical incident stress debriefing, most of the randomised trials actually show that there is no efficacy for it. Most people are showing a null effect. However, concerningly, there are one or two studies that actually are suggesting it may impede natural recovery. So critical incident stress debriefing is not an ideal model to deal with trauma in the immediate aftermath. And it's not that it's problematic for someone to talk about their experiences and their feelings immediately after the trauma. That's perfectly okay. But with critical incident stress debriefing, the way the model was, typically was everyone was sat around a table and everyone was made to disclose what they felt. And that is what's the problematic aspect of it. So what do we do instead? We've still got to do something. Well, we give people information. You know, people working in disaster services now are really trying to work on how can we promote the type of information flow that we need. How can we get people to safe places and give them the necessary resources and give them a bit of information about normal types of trauma reactions. But what we want to do as well is monitor their distress. So it's almost like it's a staged care model. And if we find that people after a couple of weeks are still really expressing a lot of trauma reactions and acute stress responses and they're not seeming to go down, then we can start to think about getting them into some early interventions and some treatments. So If we look then at these mass trauma events, then resilience is really one of the key answers. Most individuals, even with exposure to the mass trauma events, will recover and not require psychological intervention. And, you know, some of the studies that have come out, especially around the Bali bombings, have found that community engagement, bonding and social support foster this resilience. So they found, the Bali bombing study showed that social support was actually the best predictor of resilience and adaptation. As I said, in the 9/11 attacks and the County Omagh bombings, there was a relatively low use of counselling services straight after those events, and the feedback back on the ground was, we already have enough support. I'd rather go and talk to my family member who I trust than come to see a psychologist I don't know. Okay. There's also the whole concept of post-traumatic growth, because, you know, when we look at PTSD, we're often looking at the negative outcomes, but people do actually report some, you know, greater ties, greater community bonds, greater community focus, greater strength in themselves through coming through that. And those are all aspects of post-traumatic growth. And interestingly, people are now starting to look at what's the role of social media in all of this. And we can see that with the Manchester experience and other more recent events that people are getting on Twitter and social media and offering places to stay and offering assistance. I was down in Tasmania for the bushfires, you know, and there was a website set up where people could all share resources. Scarily, you know, supply a lot of beer to the Dunalley pub was one of the main things that seemed to be on everyone's agenda. But anyway, you do what you can. That's not so optimal, but, you know, it's not going to quibble. All right, what about media exposure? So that is something that's really concerning because of the level of saturation of the imagery that we might get. From the studies that have been done, and a lot of these were done around September 11th, so they were monitoring people's amount of media exposure relative to their proximity to the event, and then whether they directly witnessed anything or just saw it via media or were actually there. And there's not really convincing evidence in adults that this saturation of media exposure actually can lead to PTSD. It may lead to some increase in distress or anxiety, but that's similar to what is reported in most people after one of these events, but it dissipates relatively quickly. There is evidence, though, that it's more problematic for children to be exposed to these images. So really, the World Health Organisation has now got a recommendation that children be restricted from watching traumatic events on TV. And if they are exposed, sitting with them and explaining what's happening and checking out what the children are actually interpreting, because children can make incredible misinterpretations or see that and then think that's going to be in my immediate environment and feel very unsafe. So it's really important to be talking to them about that and comforting them as well. All right, so that's all I wanted to say around the mass trauma events. Now what I'd like to do is talk a little bit more about PTSD. Now, PTSD is one condition that can develop from trauma, but it's not the only one. And as I said, most people who experience trauma actually don't develop PTSD. So there are many, many traumas out there that we might have. You know, there might be parental neglect, there might be poverty. All these things can actually be construed as having a traumatic effect on someone's development. But I'm not going to be that broad here. What I'm going to be talking about is trauma in the context of post-traumatic stress disorder and how we define it. All right, so this slide just gives you an idea of some of the proposed mechanisms that we have involved in PTSD. And I do a bit of work in most of these fields, which just looking at makes me feel tired. But what we've got here is emotional memory consolidation. So one of the defining things about post-traumatic stress disorder is we're getting these intrusive, distressing memories that are fragmented and just coming back in. We don't want them there. We can't control them, they keep coming back no matter how much we try and avoid them. So we think that trauma memories are consolidated in a different way in the brain. And so that's one area that we're looking at there's a fair amount of research on. Also looking at the cognitive variables, threat appraisal and expectancy. So if you're working with someone who has PTSD, often they've got a very strong hypervigilance and this strong belief that danger is going to happen and these traumatic events may happen again or that the world is threatening. Okay, so they go into a bit of a survival mode where their body is constantly undergoing a hyperarousal state. That might lead to panic and excessive anxiety, or it might lead to anger and aggression at times as well. We also have overactivity in threat detection networks. So in the brain, we've also seen this hyperactivation in these threat appraisal and fear networks in the brain, as well as an impaired inhibition frontally on those. And we'll talk a little bit more about that. I'm really intrigued by the idea of a problem with contextualisation. Okay, so many people with PTSD really report that when they talk about the trauma memory, it doesn't have a coherent narrative. It doesn't flow in a sensible story that makes sense, and it's not integrated into someone's autobiographical memory. And it's very fragmented. It's triggered readily by stimuli that are in the environment. So one of the ideas is maybe individuals with PTSD have a fundamental problem with contextualisation. And, if we look at that in a anecdotal sense, looking at people who've been into a combat zone, where, they're trained to be hypervigilant. They're trained to be on alert and in that survival mode and arousal, and that's very adaptive at that time. But coming out of that situation and then trying to transit back into civilian life is very, very difficult for individuals with PTSD. And some of the other brain imaging studies that we've got are suggesting maybe this is related to an impairment in hippocampal function. I'm going to talk a lot tonight about fear learning and the extinction of fear. So some of the basic models we've got of PTSD are that we've got this fear conditioning process that happens that is involved in the development of PTSD, but we've got an impaired fear extinction learning. So an impairment in the ability to reduce fear when you're in a safe context. And this is really stimulating a lot of research. This model we've been using quite a lot to look at what's underlying PTSD and, importantly, how can we actually treat it as well. So we'll talk a little bit about that. Emotion regulation and the hormonal issues. So we know that there's really strong hyperarousal and stress hormone activation that also go along with PTSD. So that's just a bit of a gamut of some of the things, and that's not all of them, that are involved in some research areas that are pretty active. So what is trauma? Well, as I said, I'm going to talk about this more in the context of PTSD. We know all of us will experience negative and potentially life-changing events, okay? So how do we define what's a trauma and what's not? And, there's been a lot of controversy and criticism about PTSD as a diagnosis because of this very issue. And some people have been arguing, look, there's this real bracket creep where, any kind of experience that's negative may be labelled as trauma. In the context of PTSD, though, how we define trauma is that it really has to be an event that actually threatens your physical integrity, or you're directly witnessing that in others. Well, that's how DSM-5 is now classifying it. Interestingly, the old idea about trauma was that it was a normal response to an abnormal event. Well, we don't think that anymore. In fact, trauma is remarkably common. And PTSD is actually relatively an uncommon response to that common event. All right, so, and we always confront this as trauma researchers, because if you're doing a study and you're putting a media ad to recruit people with who've been exposed to trauma, again, I had a guy ring me up who'd been retrenched from his job, and he was an older man, and the likelihood of him actually finding more work was actually slim. Realistically. But again, even though that was a really life-shattering event to him, that wasn't classified as trauma, as we talk about it in the world of PTSD. Okay, so what is PTSD? I thought I'd just go very briefly into this so we can discuss, get an idea of the flavour of it. We know it involves re-experiencing symptoms. So not only the nightmares and the intrusive memories, but also flashbacks, which means you sort of lose track of where you actually are because that trauma memory is so vivid and you feel like you're back there and it's happening again. Also distress to reminders and physiologic arousal. And then there's avoidance, trying to block the memories, which makes perfect sense, or, you know, avoid things in your environment that might remind you. There's negative cognitions and mood, and that's been a change in the new diagnostic criteria we have, but that's again very common in PTSD. That the way you think about yourself and the world can really change after the trauma. And then our hyperarousal responses, so anger, startle response, and constantly feeling on alert and looking around for danger. All right, so, you know, one thing that we've learnt in how our thinking's changed over the last 10 years or so is really looking at, and we've done a lot of really longitudinal prospective studies. This one within 1,100 people who we tracked from emergency, and we tracked them for 6 years. And what you actually find after experiencing one of these types of traumatic events is that most people develop depression or generalised anxiety, not PTSD. So PTSD, about 10%, maybe 12% of people will develop it, but depression and GAD, 15 or 20% of people will develop that following a trauma. So, you know, it's interesting that we're starting to recognise the heterogeneity that's involved here. There's also, as we said, a growing wealth of research that trauma itself can impact on the brain, and especially on development of the brain. So Sarah Whittle and Nick Allen and people are doing some fantastic research in that field. And we're seeing that, you know, trauma can impact the brain even without PTSD. All right, so again, just similar to the story about the mass trauma events, resilience is the norm. So approximately 70% of us will experience a criterion A trauma in our lifetime, and the criterion A trauma is that one involving life threat. Now myself, I've actually had 8 car accidents, so if there's one take-home message tonight, it's don't get in the car. Don't get in the car with me. I even set one on fire accidentally one time, but that's kids' favourite family story. So even though we've got 70% of us who will develop a criterion A trauma, only 10 or 15% will develop PTSD. So most people actually display some symptoms in the first week or the first few days, and that's perfectly understandable and normal to have happen. So when we used to go and work on the acute trauma wards in the hospitals, the nurses would be ringing us going, oh, they're having some bad dreams and some images of the car accidents. You've got to come now and treat them on day 2. And we'd go and meet the person and try and reassure them, give them a bit of information, but we're not going to do active treatment then, because most likely they're going to recover. So this graph shows you that. It's the weeks post-trauma, and then the percentage of people who are having some PTSD symptomatology. So what you can see is when you get to about 12 weeks, where you've got that group of people, 10 or 12%, they're the ones, unfortunately, that will go on and develop more chronic PTSD. So a key question, I guess, we have in the field, which we really haven't resolved as yet, is what are the predictors of risk for PTSD and what are the resilience predictors? This is vital, you know. There are so many large-scale studies, longitudinal prospective studies now going on, especially within the combat world. People are doing massive studies of everyone that is going through Iraq and Afghanistan, trying to identify biomarkers. We haven't really had much success as yet. So looking at different specific biomarkers, we really haven't found anything that's specifically predicting PTSD. Genetics and epigenetics, we've been a bit slow off the mark, so we're only just starting to gather enough data to start to do a proper genome-wide association study. So we're currently collecting, we've got about 15,000 samples and it's growing, but from those consortiums so far we're finding nothing, no hits whatsoever so far. We know there's hormonal HPA axis dysregulation. We're looking at the neurobiology. Are there cognitive variables involved? Are there psychological vulnerabilities and psychosocial ones? And what about the impact of cumulative trauma? So all of these things are actively being studied. So this is what we do know, some of the pre-trauma risk factors. So vulnerability factors. If you've got a premorbid anxiety, mood or substance disorder or a family history of psychiatric disorder. If you've already had traumas, so if you've already had traumas, it's a cumulative effect. You're more likely to develop PTSD if you have a subsequent trauma, okay? And it's interesting working with someone, I worked a lot with police officers over the time, you know, and some cops would come in and go, look, I've seen 17 fatals, and this one I've got PTSD to is not the worst. Why is this? There were far worse, but this is the one, and they don't understand why that is. And it's often the effect of that cumulative trauma. So even though the first one might have been worse, when you get to number 10, you've got the cumulative effect on your neurobiology. But there's also cognitive variables involved there. It's the meaning that you attach to a trauma as well. So, often if a police officer is dealing with an event that involves children, then it's much, much harder to have their usual defence mechanisms put up and their distancing that most people who are first responders employ. So then again, that is going to actually do a lot more to shattering your belief systems and being much more significant, which may then lead to PTSD. Low social support and family instability are also factors. As we said, this reduced hippocampal volume, we've actually found that pre-trauma can be a predictor of developing PTSD. And is that related to this poorer capacity to contextualise? Because we know the hippocampus is involved heavily in some of these contextual processing. We've also found evidence of impaired fear extinction learning and being female as well, which is one of the questions that I'm very interested in. I'm not going to present data on that today, but we clearly know from our research that being female increases your risk of PTSD. Now, what's that about? Some people have said, is this because women are exposed to more interpersonal violence and especially sexual violence? And that certainly is a contributing factor. However, it's not a full explanation. If you model that, or if you compare males and females who've both had that history, females are still developing PTSD at twice the rate that men are. So we've got to look at some other factors that may be involved. Another question is it that women actually go to see doctors and men don't, And so is it this health service usage? But we also find this effect when we're looking at people who are in treatment or treatment-seeking samples, as well as just more broad community sampling. So again, that can't really be the answer. Now, my main interest or area I've come from has been biological. So what we're starting to do now is look at some of these processes like memory consolidation, stress hormones, and how they affect how we consolidate memory, and fear extinction learning. And we're looking at gender to see is there, or more specifically at sex hormones, to see if there's an effect. All right. What about post-trauma risk factors? So we know that this isn't rocket science, but if you have more symptoms of PTSD 1 or 2 weeks later, you're more at risk of developing PTSD. I'm sure someone was very happy when they found that effect. Again, we all know, if you've ever had a car accident, I'm pretty well versed in these now, you don't remember the impact. Most people don't remember the impact. Even if you haven't had a TBI or loss of consciousness, most people do not remember the impact, or time slows down and you sort of come to and there's the shattered windscreen, or your dad saying the F word for the first time when you're on your learner's licence. That was great. That's a good one. Anyway, but what we do know is that sort of peri-traumatic or dissociation at the time of the trauma is not predictive of PTSD. So again, that's quite a normal response. But what we do know is predictive is if that persists over time. And we've now got enough evidence to show, look, there is a subset of people who have, rather than having a fear response with PTSD, they actually have a dissociative or numbing response. And so that has now become another subtype within DSM. Richard Bryant, when I worked with him when I was a lowly PhD student, made me go to Westmead Hospital and go down to the bowels of Westmead Hospital and look through about 3,000 medical records to get their resting heart rate data from emergency, because he clued onto this great idea. What we know about PTSD is that people tend to have heightened noradrenaline, or an adrenaline response, which again makes sense. In the trauma, you've got a life threat, you're going to have a massive rush of adrenaline. What Richard did was, well, what I did and about 3 other really long-suffering people, we found the resting heart rate data, but what we found, which was pretty incredible, again in a large sample of around 1,000 people, if you have a heart rate that's elevated, resting heart rate elevated when you're coming into emergency after a trauma, you are 3 times more likely to develop PTSD. So if your heart rate's around 85 or 90 beats per minute, then you're more at risk of developing PTSD. And that finding has been replicated about 14 or 15 times now. We know, as I said, the negative interpretations or rumination about the trauma and its effects, the meaning of the trauma, is also really significant and important for people. So it's about your worldview being shattered. Okay, so I had 2 clients. One came in the morning and he'd had an absolutely horrendous time where he'd been tortured and stabbed and, threatened, genuinely awful for 2 or 3 hours. Didn't have any PTSD. And then I saw a little old lady who'd had a bag snatched and she hadn't been physically injured. She'd been pulled along the street, a little flagrant PTSD. So what's going on there? What we know is it's the meaning that that has to you and how much that's threatening your worldview. Okay, so the guy that I saw was actually a biker and he was involved in gangs and had a lot of those types of experiences. So it wasn't, unfortunately, for him out of the norm of his usual modus operandi, whereas the little old lady had never, ever, ever been exposed to any kind of threat. And so for her, it really shattered her worldview and her sense of safety and self. So I'm going to get on to talking a little bit about fear conditioning and extinction. So this is an area I'm particularly interested in, but why I'm so interested in it is fear conditioning and extinction, we think it's involved not only in the development but also the maintenance of PTSD, but importantly it also underpins our treatments for PTSD. So I'll talk a little bit more about that. How does it work? Well, with fear conditioning, what we think happens is, when you have a trauma, you have a massive the trauma itself is the unconditioned stimulus, the hugely aversive stimulus. It leads straight away to this massive release of stress hormones and a fear response, a huge fear response, naturally, the unconditioned response. Now, that fear response becomes conditioned to other stimuli in that environment that you weren't scared of before, that were neutral. So it might be a green car, or it might be hearing sirens. In one situation, it was a lady with a paper bag because a gun had been pulled out of a paper bag, okay? And every time then, once the trauma's over, because of that fear conditioning, when they then see a green car of that similar shade or hear a siren, because of the fear conditioning, that triggers that huge conditioned fear response. And if you then avoid going near places because you're fearful of seeing those things, then it can maintain this conditioned fear. All right? So that is the basic idea. And this happens on an unconscious level. So that particular lady who'd been held up in a hold-up, she came into me thinking she was completely mad because she was having full-blown panic attacks when she saw brown paper bags. I mean, what's that? That doesn't make any sense at all because she couldn't remember that the gun had been pulled out of a brown paper bag. It's such a minor detail that you wouldn't actually recall it. Unfortunately for her, when you're out in the general public and if you have a panic attack, what do people do? They give you a brown paper bag. So she was in a real mess. It wasn't great for her. Anyway, but when we actually started to work through the trauma memory and do some of the therapy around it, she actually realised where the gun had been pulled out of. And then everything just clicked and fell into place and made perfect sense for her around that. So it's not a conscious thing that people are choosing. It's an unconscious process. All right, so if fear conditioning is the mechanism that leads to the development of PTSD, why don't 70% of us have it? Because 70% of us experience a criterion A trauma. Can't be the only answer. We know that it's involved in the process of the development, but actually when we look at our empirical evidence, when we get people in a psych phys lab and we do a basic fear conditioning and extinction study, we don't find that people with PTSD have heightened fear conditioning. Okay? So there's not really a lot of evidence for that. We know that it's involved though because what we think's happening is rather than it being fear conditioning, it's fear extinction. All right? So if you've had a car accident, the first time you get back in that car and try and drive, you're pretty shaky. You're often terrified. You may actually just go up and down the driveway a bit or just go to the local shop and then you come back. And as you come back, you're shaky, but you're a little bit calmer. And the next time you get in the car, you're a bit calmer. Your fear's not as high. You might do the same and venture out a little bit more and come back. Nothing bad's happened. Your fear comes down. That's actually fear extinction learning. All right? So that's a natural, and we think that's underlying the natural recovery. What we think is happening with PTSD is that that process is impaired. Maybe because people are so anxious that they're avoiding getting into the car altogether, so they don't actually get the chance to do the fear extinction learning. Or is it actually that they're impaired in the actual capacity to regulate and reduce their fear over time? So with that model, unfortunately that means that we all have to shock people or give them, startle responses, because we actually need to test out fear conditioning and extinction in people to see, is this actually a process that's impaired? So the typical task we use is we show people coloured circles, neutral images, neutral stimuli, just like you would for a trauma. And then in the acquisition phase, we give people an aversive stimulus that's paired with one of those coloured circles, which becomes the threat signal. We only do it about 5 times, but people develop a very strong arousal response. So they increase their sympathetic arousal, which we normally measure by heart rate or skin conductance, the sweat gland activity in our fingers. And then in the extinction phase, but we don't ever shock to the other circle, so we can see this differential response. And then for the extinction process, we just give them more trials of the coloured circles without any shock, and we see how quickly over time does their arousal and their fear come down. All right? Now, what we know is that we certainly have clear evidence that there is impaired fear extinction learning, as well as the recall of fear extinction in PTSD. So here you can see that we've got people measured with a startle response. This is their early extinction learning, middle extinction learning, and we can see the PTSD is actually, it's not really dramatic here, but they're higher than the other groups. But when we look at the later extinction, you can see how the PTSDs have got much higher startle during this, suggesting they've got poorer extinction learning. And the same, this is one of our studies that we did, my PhD student did last year. Now, this one, you can see the controls actually have very rapid fear extinction, whereas the PTSDs, whilst they're still extinguished, they're doing it at a much slower rate. All right. And some people have studied this again. Richard Bryant's quite ingenious. So another thing he decided to do was look at testing fear conditioning and extinction prior to people being exposed to trauma. Now, how do you do that? You get firefighters, or you get someone who's in emergency services who are training, and you assess them before they then go out in the field where they're going to be exposed to trauma, and then we retest them. And so what Rachel Guthrie and Richard Bryant actually found was that if you had impaired capacity to reduce fear even before you're exposed to a trauma, then you're more at risk of developing PTSD later on. So it's really, again, just highlighting this role of fear extinction learning. And that's been a replicated finding in a couple of other studies. Now, what we also think is that fear extinction learning is actually, we know there's lots of different risk factors. We know there's genetics, we know that there's, poor verbal function, and we know hippocampal activity and hormonal responses, all are risk factors for PTSD. And what we also know is that all of those factors actually affect fear extinction learning as well. So a question we posed in a recent review article was, is impaired fear extinction learning actually mediating all the effects of these other risk factors onto the development of PTSD? So that's looking quite much from a biological angle, but we can't ignore these catastrophic appraisals and these cognitions that happen in PTSD as well. They're very strong, they're very prevalent clinically, and we really need to also target those. Now, there is a literature suggesting, well, look, fear extinction is all driven by threat appraisals. It's all cognitively driven. It's actually not about biological arousal. So one of the questions that my PhD student asked was, is there actually a relationship between these catastrophic appraisals that develop after the trauma? So that's with the PTCI, which is the Post-Traumatic Cognitions Inventory. What you can see there is the PTSDs have significantly higher catastrophic cognitions after the trauma than the two control groups, trauma exposed and non-trauma exposed. And we also looked at extinction learning. So we wanted to say, do the catastrophic appraisals actually moderate this relationship between the PTSD symptoms and extinction? And we find that negative appraisals are a significant predictor of PTSD symptoms. Extinction learning and the capacity to reduce your extinction is also a significant predictor, but there's no interaction effect there. So they're actually both having an impact on PTSD symptomatology, but they don't interact. All right, now I'm going to talk a little bit about the neurobiology of PTSD, because that's where I've done a lot of my work, probably earlier work looking at neuroimaging and fMRI. What we know with the neurobiological model of PTSD, from well over 70 or 80 fMRI studies now, this is really a well-replicated finding, is there's heightened activity for PTSD in this threat appraisal network. So involving the amygdala, which is involved in fear processing, but also in threat appraisal and salience appraisal, in the insula, which is involved in recognising interoceptive arousal signals in your body, as well as in dorsal anterior cingulate, which is more involved in fear expression. So that's hyperactivity in PTSD at resting state, but also in response to threat stimuli. And we also know that there's impaired inhibition. So if you look at the brain, you've got this threat arousal system, which is subcortical, but we also have medial prefrontal and regions which have a powerful inhibitory input onto those lower arousal pathways. And what we know, probably the most replicated finding in PTSD, is that there's reduced activity in those frontal regions. So it's really suggesting that what's going on for PTSD is you've got this impaired top-down inhibition onto these threat arousal networks. Okay. And this is just a meta-analysis of 79 fMRI studies that actually has clearly found evidence in support of this neurobiological model. So the key regions of hyperactivity were exactly amygdala, insula and dorsal anterior cingulate, and the key regions of hyporeactivity or reduced activity in PTSD compared to controls was hippocampus and ventromedial prefrontal. Now the hippocampus, we think, actually interacts with the prefrontal regions to inhibit those pathways. All right, now that looks like a really cool slide, and I put it up there so I looked really intelligent because I'm not going to talk you through it. It's actually a rat brain, and it's modelling the different nuclei and neurobiological pathways of fear conditioning and extinction. The main take-home message here is that in the rat brain we have the prelimbic and infralimbic cortex are actually considered homologues of these, some regions in the ventromedial prefrontal cortex and the dorsal anterior cingulate. So prelimbic to dorsal anterior cingulate, infralimbic to ventromedial prefrontal cortex. So what we also know is many of these pathways around fear conditioning and extinction are actually similar in rat brain and mouse brain to what we see in human, even though their brains are that size and our brains are that size. There's a big difference, and we've got a lot more prefrontal cortex. But we still see this conserved across species. And that's fantastic because we can actually then start to look at some molecular neuroscience and underlying mechanisms of fear conditioning and extinction. All right. So this is, some people have done fear conditioning and extinction studies actually within the MRI scanner as well. And what they've actually found is, well, this is the CS plus response for the PTSD compared to controls. And you can see it's much larger with skin conductance. And this is during the extinction phase, so it's suggesting PTSD have poorer extinction. But what's really interesting is the neural correlates of that. What we can see is the PTSDs have greater amygdala activity during the extinction phase, and they have reduced ventromedial prefrontal activity during that extinction phase. So they're actually giving the fear conditioning extinction task in the scanner. So that is really, again, quite compelling. And again, that study's been replicated 2 or 3 times. So, you know, it is giving us quite convergent evidence around this impaired process. So what? This is all great. This is all conserved across species, and it's all looking very convergent and neat. But so what for treatment? So how is this knowledge actually helping people with PTSD? We know PTSD is a chronic, highly distressing condition which causes functional impairment, relationship breakdowns, and it's associated with many other comorbidities. So we've got a really urgent need to improve treatments, okay? We do have some good evidence-based treatments, but despite decades of intensive research, no effective pharmacotherapies are currently existing for PTSD, despite 30 years of research. We have not found specific biomarkers or specific mechanisms that have led to the development of specific pharmacotherapies for people with PTSD. Many people with PTSD are on SSRIs or SNRIs, and that can have a positive impact, but sometimes it has no impact at all. But it's not targeting the specific mechanisms and the specific core symptomatology of PTSD. Often it's treating the comorbid depression, which is very high in PTSD, and so on. So what is our first-line evidence-based treatment for PTSD? It's trauma-focused cognitive behavioural therapy. So, and when we look at all of our randomised control trials, I was a clinician on a trial that we did that took Richard Bryant over 10 years to do, and it was incredibly involved. But what we were trying to do is break down the different treatment elements or components within trauma-focused CBT to see what is the most effective aspect of treatment. And clearly what it is exposure therapy. So imaginal exposure, where you're going through the memories of the trauma, and in vivo exposure, where you're getting people to gradually go out and confront reminders of the trauma. And we've got over 80 randomised controlled trials showing efficacy of exposure-based therapy, but the kicker is about 30 to 40% of people are only displaying a partial treatment response, or they're displaying no treatment response. So we still need to work at improving our treatments. Now, the proposed mechanism that's underlying exposure-based treatment for PTSD is actually fear extinction learning. All right? If you think about we're exposing people to the memory of the trauma, but nothing bad is actually happening to them in the room apart from revisiting that memory. And if we're exposing them to things that remind them of the trauma, but nothing bad happens, that is actually fear extinction learning. And we need to do it repetitively, over and over. And what we typically see is people's arousal and fear starting to come down, and then their symptomatology starts to come down. We did this is last century, we did a very small pilot study where we looked at, we just showed people fearful faces because that's a really robust stimulus to sort of look at amygdala in the brain. But we did it before and after exposure-based treatment, okay? And what we actually found here was that there were significant correlations in line with this idea that fear extinction learning is occurring in PTSD. We saw changes in some specific fear extinction networks in the brain, which was the rostro-anterior cingulate, that as the people's symptomatology came down across exposure treatment, the activity in that area, which is normally reduced, increased in PTSD. Equally, we saw that as the symptomatology came down in PTSD with successful treatment, they had reduction in amygdala response to fear. So this is really suggesting that one of the key mechanisms with exposure is actually an increased activity in these fear extinction networks that might be inhibiting amygdala, which was really exciting. And what's even more exciting is it's been replicated. So stuff you, all your social psychologists who can't replicate anything and have been criticising fMRI for, how many years, 40 years, 30 years. We can replicate. So two other studies have actually replicated that finding now. And this I like to put up because there was a lovely social psychologist in my last place of work, and he was always at me about fMRIs and our false positives. And so once a week he'd send me this image on email. And I don't know if you know it, but it's a dead salmon, right? It's a dead salmon that a neuroscientist, a postdoc, put into the scanner and showed images of people interacting. And what he actually scarily found was he got activation in the brain because of he was highlighting that, with so many comparisons across the brain voxels, you're getting to get false positives. So this lovely social psychologist used to send me this once a week. So I need to find some pithy image which sort of reflects how social psychologists can never replicate anything that I can start sending to him now with the reproducibility crisis. Anyway, so if anyone's got one, please send it my way. All right, so this is where we're getting now onto some more novel areas. So a lot of the things I'm going to talk about here Only 1 or 2 studies have been done, if at all, or there are studies currently underway. But fundamentally the question driving this is, can we identify what enhances fear extinction learning? Because if we can actually, if fear extinction learning is a key mechanism for our treatments, if we can look at research and go, we know that these different things can increase fear extinction learning, can we then apply that to exposure therapy and see if that facilitates a treatment response, especially in these people who are partial responders? So these are some of the candidates that people are busy looking at the moment. D-cycloserine is a partial NMDA receptor agonist. What about estrogen? You know? People have found compellingly now that if you've got low levels of estrogen, you actually have poor extinction learning and recall. Okay? It's largely been found in healthy controls, but the implications are quite significant. You might go, but how does that gel with the fact that women develop PTSD at twice the rate men do? But we think it's the variability. We think it's the variability in how, in a woman's menstrual phase. And again, with one of our large prospective studies that we did, we actually found, we just were asking people what day of their menstrual cycle they were on when they came into emergency after a trauma. And what was really scary was, I mean, you know, that data is notoriously unreliable. If any woman here knows when she last had the first day of her period, I'll be blown over, because it's incredibly unreliable data. But even with that unreliability, we found a very strong effect that women in a particular phase of the menstrual cycle actually had heightened flashbacks and intrusive memories. So again, there is something to this story about sex hormones, but there's been very little research done on it as yet, because no one wants to investigate gender because it's politically unpalatable, and also no one wants to look at sex hormones because it's incredibly expensive and difficult to do. I once wrote a grant and an assessor wrote back going, I don't believe sex differences exist. My entire grant was on sex differences, so I thought, oh, I'm going to get a good hearing here. But I now, with every grant I write, when it's on something around sex hormones or sex differences, I put up a graph, which was in a great review paper about 4 years ago, which basically looked at what are some of the mechanisms underlying anxiety and stress-related disorders. We know women develop them at twice the rate men do. It's learning, it's memory consolidation, and it's this fear conditioning extinction process. So they went and looked at all the animal literature and all the human literature, and they compiled them all, and there were about 14,000 learning and memory studies, and there were about 7,000 fear conditioning and extinction studies. And what they scarily found was less than 2% of them actually studied females at all. Most studied males. Which just seems so mad when women are the ones developing the stress-related disorders. So I always put that first and foremost on every grant, and then no one says anything about significance again. Works quite well. Cortisol is another one, and I'll talk a little bit about some of the treatment-related stuff. Now, how long have I got, Nick? 5? 5, 10? All right, cool. And some work I've been doing recently is looking at brain-derived neurotrophic factor, which sounds, again, I think I'm just doing things that make me sound smart. No, I don't know. But sleep is another really fascinating one. We've always just gone, oh yeah, people with PTSD have sleep problems. We know they do, and that's all because of the nightmares. But now what we're starting to think is sleep actually an etiological process? We know it actually predicts increased risk for PTSD if you have poor sleep before the trauma. And we also know that sleep's involved heavily in memory consolidation, and now there's really interesting research suggesting that sleep can actually impact on fear extinction learning. So again, why that's attractive to look at is we can do something about sleep. We can actually do some really specialised sleep interventions that may promote how people are then going to respond to exposure therapy. What about brain stimulation? That's all the rage. Everyone's really excited about brain stimulation. Does it work or not? That's another question. Is it reproducible? Another question. But again, if you've got this really compelling evidence of reduced dorsolateral, ventrolateral, ventromedial prefrontal cortical activation in PTSD, and sadly it is more ventromedial, which is much harder to access from brain stimulation. But if that is the case, if we actually increase that or elevate that, can we actually then facilitate fear extinction learning and can we facilitate exposure therapy? There's other ideas, noradrenaline, oxytocin. People are looking at ecstasy. I can't say MDMA. Yes, I can. It's all right. Jet lag hasn't quite got me yet. All right, so I'm just going to show you a little bit about D-cycloserine if I've got... I'm running out of time, but this one we know from research back in the day was found to facilitate fear extinction in rats and then again in humans. And so this is a drug that you can take in a really small dosage, about 50 milligrams, whereas the clinical dosage, which is used for different types of for tuberculosis, I think, but it's 500 milligrams. So it's a really, really small dosage that has no side effects. And people are now trialling it and giving it because it's been shown to facilitate fear extinction learning. They've been giving it during exposure therapy. And comparing that to having a placebo, they do find across several anxiety disorders that it actually improves the response. Hastens the response, so it speeds up the response to exposure therapy. In specific phobia, the first study was height phobia. I'm height phobic, so I don't like those virtual floor things. They stand people on a platform and then just, it opens and suddenly you're at different heights and you stand there and do exposure to it. It's awful. And also social anxiety, OCD, they've shown this. So does it work in PTSD? No. So there's only been 2 randomised control trials. Actually, there has been a third now, but people are finding largely that there's null effects with putting DCS with exposure therapy, which is really disappointing. One study found if you get rid of all the people who respond quickly, it does facilitate exposure therapy for the people who are slower to respond, so maybe there is a clinical impact here, but it was a really small effect. What about cortisol? We know cortisol, actually the cortisol literature is a dog's breakfast in PTSD, as it is in most fields, because of the methodology that's involved and the inconsistencies in methodology and how that can impact on response. However, a recent meta-analysis, which was much better controlled than most across 47 studies, actually found there is good evidence that there's low cortisol levels in PTSD, and you go, hang on a minute, it's a stress-related disorder, how can it have low cortisol? The idea, we think, is that there's an enhanced negative feedback inhibition within the HPA axis, and that's leading to lower cortisol levels, and cortisol actually acts as a brake on sympathetic arousal down the track. So the idea is if you've got this lower cortisol that's circulating, you're actually going to have ongoing heightened sympathetic arousal. Now, why is that of interest? Well, human studies in healthy controls have also found evidence that heightened cortisol actually facilitates fear extinction learning. So if you give someone a burst of hydrocortisone, which elevates cortisol, you can actually increase extinction in healthy controls. So again, maybe this lower level of cortisol in PTSD is actually impacting on fear extinction learning and then impacting on exposure therapy. We've done a recent study where we found that cortisol actually moderated the relationships between PTSD symptoms and fear extinction learning, so that you had increased PTSD symptoms were associated with poorer fear extinction, but only in those who had the lower cortisol levels. So it's suggesting cortisol's involved here. There is a recent clinical trial which was really cool. It was only a pilot study in about 30 people or 40 people where they gave hydrocortisone during exposure therapy compared to giving placebo during exposure therapy for people with PTSD. And what they actually found was that there was greater PTSD symptom reduction with hydrocortisone relative to placebo. And interestingly, there was also an association you can see here between the reduction in PTSD symptoms and reduced glucocorticoid receptor sensitivity. So again, that's really quite a nicely compelling finding about treatment and its biology. However, they got so excited by that, they then spent inordinate amounts of money in 5 years getting together, which I've just heard at this recent conference, so it's not published yet, but they did a much larger randomised controlled trial in veterans. They had 80 veterans. They had to screen 8,000 people to get 80, so that's really a depressing thing to talk about with them. And what they actually found was there was a small improvement over standard exposure, so they compared placebo with exposure and hydrocortisone with exposure, but it wasn't a clinically significant difference. So again, it's a fairly small effect. Estradiol, as I said, has got these low levels of estradiol associated with poor fear extinction recall. There's only very few studies as yet in PTSD, and there's no published data around whether elevating estrogen can actually facilitate exposure therapy. We haven't done those studies as yet, but there are some underway in labs. Brain-derived neurotrophic factor is something that I'm quite interested in. It's a neurotrophin in the brain that is involved in synaptic plasticity and learning and memory processes. And there's been recent evidence in animals that if you inject BDNF, which is the arrow, into the infralimbic hippocampal networks in a rat, or sorry, is it a mice? I can't remember. But you obliterate conditioned fear. So you've done conditioning, but when you put BDNF in there, so the BDNF is the one in the black circles, and that's saline or a control, you eliminate conditioned fear. Okay, so it's suggesting, wow, what's going on here? And a study around the same time looked across mice and humans. So this is looking at the BDNF genotype, the Val66 MET. The MET allele, which is the VM one here, and the VM and MM one here, actually has low expression of BDNF. So if you've got lower expression of BDNF, you've got lower synaptic plasticity, you may have impaired learning and retention and memory. And what they've actually found here is that the low expression BDNF across mice and across human have poorer fear extinction learning. And they also did this in the scanner, and it's very hard to see this, but in humans, associated with that was a reduction in ventromedial prefrontal cortex and an increase in amygdala. So again, quite nicely divergent, or convergent, sorry. So then I was sitting there being opportunistic and going, wow, we've just genotyped all these people and we've got clinical people with PTSD who've just done exposure therapy. Let's have a look at their BDNF. And that's exactly, we found something similar. It's not a huge effect, but it is significant that the people with the low expression BDNF MET allele had poorer response to exposure therapy. And that actually was predicting 14% of the variance in the symptomatology change, which is quite large for a genetic study. So the question really is, can we enhance BDNF during exposure therapy? And will that make a difference? Brain stimulation, there's a whole bunch of things being trialled. Repetitive TMS has some effects, but again, there's not really great evidence. Intratheta burst, there's some trials going on at the moment, but nothing's been published. I'm looking at TDCS, mainly because it's more amenable to clients and clinicians. However, there's a big question, does it actually work? So you've always got to do one study that could be potentially very expensive and a dramatically spectacular failure, so that's mine. Anyway, sleep. We know that sleep has an impact on memory consolidation. Again, this is looking at hours of waking, and what you can see with this one is that hours of waking is moderating the relationship between PTSD symptoms and fear extinction learning, such that if you've got higher PTSD symptoms, poorer extinction learning. That happens when you've got a longer time with hours of waking. So it's suggestive of an impact of sleep. And this is a really cool study of a colleague of mine where they did spider phobia exposure therapy just online, showing people images of spiders, and they've got fairy teddies that are spiders. And then they randomised people to go and have a nap for 90 minutes or to stay awake. And they found napping facilitated the response to exposure. All right, and I'm not going to really have time to do this, but can we prevent PTSD? This is a bigger question where I don't think the science is anywhere near it yet. But people have looked at propranolol, that's a beta blocker. So if we have got this hyper-adrenaline response in the initial few hours in emergency, we've got this higher resting heart rate predicting PTSD. We know heightened noradrenaline actually is leading to greater memory consolidation. I haven't talked about the memory consolidation studies we do, but we clearly see this. So the question is, if we can reduce that adrenergic response within the initial few hours after trauma, the memory consolidation window, maybe we'll reduce the memory consolidation. Maybe we can actually prevent the development of PTSD. It's a cool question. There's been 3 randomised controlled trials that have studied this, and no, we don't find it. There's nothing, which is really unfortunate. But again, it's very hard to do this work. Try and convince emergency physicians that you need to, give them this drug. Try and convince a patient who's in serious pain and is just really dishevelled and just wants to be with the family, oh, here, take this drug because it might prevent something you might not get anyway. It's tough, outside of all the other chaos that's going on in emergency. What about cortisol and hydrocortisone? So it's not been really strongly found to affect exposure therapy, but what about in emergency? Because cortisol, again, we know is involved in memory consolidation. So there is some promising evidence, but again, these are tiny pilot trials. There are bigger studies now ongoing, but giving people hydrocortisone in emergency and over the next few days, what they found was the hydrocortisone group, the percentage who had PTSD symptoms at 2 weeks was lower than the placebo. And then if you look at 3 months, no one in the hydrocortisone group developed PTSD, but about 35% of the placebo people did. However, this is minuscule numbers, like 10 in each group, so we really need to explore it. What a friend of mine's doing at the moment, he's looking at FKBP5, which is a co-chaperone protein which regulates glucocorticoid receptor, and it's been associated with risk for PTSD. He just did a meta-analysis of human and mice studies and showed this FKBP5 genotype was associated with risk for impaired fear extinction. But interestingly, he found administering dexamethasone, which is like a synthetic cortisol, actually modified and corrected that effect in amygdala. So now he's doing a trial where he's actually going to administer dexamethasone in emergency and see if that has any impact on preventing PTSD. Just quickly, memory reconsolidation was all the buzz a couple of years ago. What this idea is people used to think once you have a trauma memory, it's indelible, it's imprinted on you and it will never go away. What we know now, though, is if you give a cue that's a reminder of the trauma, then it will make the memory come back in a labile state. And if you can do fear extinction learning in that time, or something else, give propranolol is another thing people have done to reduce the adrenergic response. Can you actually erase the memory? It's quite a controversial idea. Meryl Kint's driving this work. She certainly finds in healthy controls that if you bring back and cue this memory and then give propranolol, you erase the conditioned fear. So she's done it in fear conditioning studies. However, it's problematic for PTSD because there's really clear boundary conditions on memory reconsolidation, and one of them is it doesn't work for old, stronger memories. So that's problematic for PTSD. Maybe for acutely traumatised people it may have an effect, and again, studies are underway. And the last one's really crazy, but just been published by Emily Holmes, who's at Oxford and is super bright. She is chasing people in ambulances immediately after emergency and making them play Tetris. Sounds completely bananas. However, the model that they've got is that we know the trauma memories are fragmented, they're visual, and they're associated with intense arousal. So their neurobiological model is that the memories are stored in visual storage and using visual networks, whereas when we actually start working with people with the trauma memories, we have a verbal process that happens that actually is involved in contextualising these memories, making a coherent story out of them. So her argument is, in emergency and in that consolidation time immediately after trauma, if we can actually occupy the visual system by playing Tetris, maybe that's going to give more resourcing to the verbal system, and maybe that will be a preventer of PTSD. So only one study has come out. It sounds crazy, but, we're willing to give anything a go. All right, so that's all I wanted to talk about. I don't know if we've got time for questions or not, but that's given you a bit of a snapshot. Anyway.
We do have time for a few questions, so please fire away.
I think I've covered every controversy known to mankind in that one, so I'm sure there's questions. Yes, Judy.
Thank you very much for giving that. Fascinating. Do you think there is any role to play of the peer group of the people who are involved in trauma? And this is sort of anecdotal evidence from watching processes. It seems to me that people who are suffering more with PTSD, more serious symptoms and more disability are those people who are in the police force, emergency workers, and those sorts of people who are not only facing it daily, but their peer group are not accepting of their symptoms, whereas these one-off events like Manchester and 9/11 and so on, they are one-off events. They're very traumatic, no doubt, but these other people, and the same with the Vietnam War veterans. Is there any evidence that might suggest there are sort of two quite distinct sorts of groups when it comes to that kind of trauma?
I don't know if it's about distinctive groups, but I think you're talking about distinctive organisational cultures, which really have a strong impact on how and when and the methodology you can actually respond to trauma. Absolutely. And try and get anyone to agree to study organisational culture when you've got to recruit people from a workplace at an organisation. You're trying to slip a few questions in there. Look, I think it's vital. I think the peer response, the social support that you actually get is really important. And we've got that over the last 30 years, that social support, whether it's from your close sphere or whether it's within this work context, absolutely is critical. You know, other things as well is loss of identity and role. So if you are in the emergency services or in combat or Vietnam veterans and you leave that environment, you've got all this loss of role, loss of identity, loss of peer group. So there's all these other compounding factors. You know, we just did a study with social support where, though, you know, the idea was, well, if you've got poor social support after the trauma or beforehand, then it's a predictor. But what we did, and I didn't do it because I cannot do stats, but my colleague did a cross-lagged analysis where she actually looked at what is there a bidirectional response, and we certainly find that PTSD, after the trauma, if you've got poor social support, predicts PTSD. But when you have PTSD, it predicts poor social support because you're pushing people away. There's a lot of social isolation. But one study we're going to be doing, we're now starting to look at adjustment in refugees, and we're starting to look in children and adolescents. And that's one of the questions that I really want to explore is, what is the role of trauma and PTSD, and is it moderated by peer relationships, which I suspect will be really strongly. Yeah.
So in the DSM-5, there's been the addition of secondary traumatic stress.
Yeah.
So which is where you are traumatised by hearing someone else's story without having witnessed it or being a part of it yourself. I wonder. I guess I'm wondering, some of the evidence, or some of the empirical evidence suggests that people having their own histories of trauma can promote that. Do you think that there's a distinction between secondary traumatic stress and primary traumatic stress?
Yeah, you know, really good question. Absolutely. You know, and certainly I think that came about because of emergency people. So, you know, people who are looking and being continually exposed to cases and stories of really horrible child abuse and things like that repetitively, we know can really significantly develop PTSD. So secondary traumatic stress can occur. However, we haven't done the studies to look at whether it's distinctive in any kind of neurobiological way or cognitive way or anything. So, you know, the field is really new at looking at heterogeneity. I think where we've been guilty is we've all gone PTSD is this one thing. It's not. It's a syndrome of symptomatology. And, you know, the first thing I teach anyone clinically is just because they've got a diagnosis of PTSD does not mean a one-size-fits-all model. What you have to do is look at the symptom pattern. People's meanings and constructions around this and that context. So look, I think, you know, that's where we need to go, and I think it being in DSM-5 actually stimulates research as well. So I think watch this space. I think we'll be looking at that a bit more. Yeah. Yeah.
Thank you for a lovely lecture. I'm curious about what classic memory enhancers like acetylcholinesterase inhibitors do to extinction learning. Is there any work on that suggested?
Yeah, not that I know of in the recent times. Whether there's been stuff that's been done previously, maybe, but yeah, I don't know of any myself. So again, you know, it could certainly sound feasible. You know, what we're doing at the moment though, there's a bit of a rush on, like every man and his dogs where's a neuroscientist I can hook up with? And all the neuroscientists are going, oh, where's a clinician I can connect with? And everyone's on this search for these cognitive enhancers. But, you know, we haven't, I think the one that's showing most promise at the moment may be cortisol, but, you know, there's nothing compelling, sadly, at the moment. Yeah. Yes, up the back.
Have you a comment on EMDR?
We could talk about that for hours. No, look, it's got evidence. It's got an evidence base behind it, so that now it's included in all the expert guidelines as a intervention that is effective. So there's undeniable evidence with good quality randomised control trials that it is effective. What the underlying mechanism is, I think that the jury's out. You know, some people would say it's fundamentally just exposure because you're keeping the image and the memory in mind. It's probably a more palatable way to do exposure for the client, so there's probably... But I think there's equivalent dropout rates to our standard forms of exposure. However, you know, some of the other neurobiological theories, I think they need more evidence and research behind them. So, you know, I haven't seen anything that really compellingly convinces me around the mechanism underlying EMDR as yet. So, yeah.
We have time for one more question, so you win.
Does it matter in terms of the length of time in which a person is diagnosed that affects the person's prognosis and recovery, or does it not matter? Because some people can have severe trauma, but is diagnosed in a short period of time, that might affect their recovery as well?
Yeah, look, that's a really good question. I think, you know, from what I've seen, you can we've got different trajectories of PTSD. I guess that's something else that's come out of some of these really large-scale studies that we're doing. Typically what we say is we don't really diagnose, I mean, DSM says the first month, but typically when we're really starting to treat PTSD, it's around 3 months, because that recovery process can be slowed at times. There can be other factors, like people might have an orthopaedic injury and the pain signals are actually a really big mutual maintainer of PTSD. You know, there's other adjustment issues that are happening in that time. But, you know, certainly you can, we've seen some people who develop it immediately and then are really chronic. We have other people who develop it and then improve over time. We have some people who are doing okay and then they develop it. And then we have people who are largely resilient. So they're the typical trajectories that we've witnessed. But again, the research is only just starting to now go, okay, let's take these trajectories and then look back. Do they have different symptomatologies? Do they have different mechanisms? Do they respond differently to treatment? Again, that kind of research is in its infancy at the moment. Not doing much to sell the field, am I? It all sounds like we're doing nothing but sitting around.
Lots to be done. So look, I wanted to just thank Kim for what was, aside from some gratuitous criticism of social psychology, a really compelling public lecture. Thank you, Kim. That concludes our May lecture series. I want to thank people for coming along. If you liked what you heard, and how could you not, please do stay tuned to our other events. If you're not on our newsletter, it's very easy to sign up for our monthly newsletter, which contains information about all our events on our website. We're going to be taking a break from public lectures and events for the next couple of months, but then soon after that, when semester starts, there's 3 terrific events coming up. Just to give you some advance warning, we're going to have Jason Fort from the school talking about direct current brain stimulation, whether it works. Short answer, no.
Damn.
But come anyway. There's going to be the Alice Barber lecture in collaboration with our psychiatry colleagues on old age psychiatry by Nancy Pahana from University of Queensland. There is going to be a mystery lecture in early September to speak on a topic in collaboration with the Australian Psychological Society. So August, September is going to be a great time to come along to more events like this, and I hope you do. So thank you for coming.
Was that okay time-wise? I had no idea if it was be or not. Right. scary how much you think you don't have anything to say and then you realise